Hi, welcome. I'm Darlene Hutton, owner of QRS Education, and this is the first in the series discussing airway management. So please go ahead and like once you've had a chance to view this and subscribe to our YouTube channel. The first section we will be looking at is going to be basic airway management. So let's start at the very beginning by seeing this unresponsive patient. First thing we need to do is do our scene survey, and we need to ensure that the patient is unresponsive. In a hospital environment, we will be having our personal protection equipment on, so assume that that's what you see on me as I present. Are they responsive? As I call for help, I will be assessing a pulse check. I will also be observing to find out if there's any attempts at breathing, agonal breathing, or no breathing at all. In this particular case, the patient does have a pulse, but I observe that there is no respiratory effort. So I'm going to do the head tilt chin lift. I'm going to look in their mouth to ensure I don't see any foreign bodies that may be obstructing the airway. If this patient was a trauma patient and I was concerned about potential C-spine injury, I would not do a head tilt chin lift. Rather, I would do a jaw thrust. In a jaw thrust, you're going to take the angle, the lower jaw, the mandible, and you're going to be pushing it upwards while with your thumb keeping the cheeks down. Okay. This is not a trauma patient, although with no arms and no legs, you kind of wonder sometimes. But anyway, head tilt, chin lift, I see no obstruction. So the next thing I would do, because I have airway management kits in my bedsides, in my clinics, if that's where you're working, is we need to insert an oral airway. Oral airways are sized from the angle of the mandible to the entrance of the mouth. I've got two here, and you can see the angle of the mandible to the mouth. This one would be a bit too long for me. This one is good. The only contraindication to putting in an oral airway is the patient has a gag reflex. If you have a patient who has a compromised airway, yet they are still conscious, the alternate would be a nasopharyngeal airway. When inserting this into the nostril, you lubricate it first, and you want to ensure that the angle or the beveled edge is where is going towards, the angled edge is going towards the septum. So for the nasopharyngeal tube, you're going to insert it straight down until you are seeing it just at the tip of the nostril. If you feel any resistance, do not push past that because you don't want to have a bleed, let's say from a polyp. Let's go back to the oral airway. When we insert the oral airway, it is going to start off by going upside down into the mouth. And when you get to the junction of approximately the hard palate and the soft palate, you're going to rotate it and continue inserting it down. Now that we have our oral airway in, we're ready to bag our patient. You're going to get the Ambu bag, and you will need to possibly put everything together. The nice thing about how this equipment has all been designed is you can't connect it in properly. You always want to ensure that you do have a filter, and a lot of the newer bag valve masks do have built-in filters. The other thing to be mindful of is how to place the mask. And I've seen some people kind of getting confused. Just a little quick tip, the narrow part is going to go to the nose. So you can use this right-handed or left-handed, whatever your dominant hand is. There's a couple of techniques that work very well at making sure that this mask has a good seal so that there is no leakage of air. The most common technique is called the C technique, where I take my finger and my thumb, place it on the mask, and I take my remaining three fingers and put it under the jaw. I do a head tilt chin lift, and then I would give a breath every 6 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000. If you're getting air leak, let's say you've got tiny hands, arthritic hands, there's a variety of reasons why the C technique may not work. Another alternate that I teach that is very helpful is a technique that not your first go-to technique. So always try with the C technique, but this one you take your whole hand, put it right on the mask and push it down. You can clearly see now, though, that I have obstructed the airway. So as a reminder, take that little pinky, put it underneath to do a head tilt chin lift. And that might get you a much better seal. Okay, so every 6 seconds. And it is important that you count out loud in your mind. Do not get distracted by talking, because sometimes that means that you will hyperventilate your patients. That is it for our airway management part 1. So as I said, please subscribe to the station and I'll be right back with part 2. We will be looking at different ways to assist with intubation of the patient. Thank you.